Hello, everybody. Thank you so much for joining us today. My name is Stephanie. I am with Senior Advocate, and this is our Zoom series that we are doing the second Wednesday of every month. So welcome. I see some new faces and some people that I have not met before. So I think you guys are in for a really great, interesting presentation today. Before we get started, I just wanted to do a couple of housekeeping notes. Some of you are not as familiar with Zoom as others, so I wanted to explain how you can put questions. If you take your cursor and you scroll down to the bottom of the screen, you will see a chat button. You can go ahead and click on that. That will show up on the right side of your screen. At any time during the presentation, feel free to write your questions in that box. We will look at that when Dr. Okhravi is done speaking, and then we will take care of those questions. If you're still not quite sure how to do that, what you can do is you can text me during the event. I have somebody that will be keeping an eye on my phone during the program. You can text me. That number is 757-645-6364. Again, 757-645-6364. Text me any questions you have, and we will do our best to get to them at the end of the program. Couple other quick notes about Senior Advocate. We do a magazine. We do lots of educational events throughout Hampton Roads and also in Richmond now. If you are interested in finding out about our other events, you can find out everything on our website. That is senioradvocate.live, L-I-V-E. Again, many of you registered online, so you probably are familiar with the website, but that again is senioradvocate.live.
Stephanie, I can't hear you.
Okay, let me see what I can do about that. Give me 1 second and let me just see. I think that I need to take her and put her on a different, there we go. Okay.
I can hear you.
Okay, excellent. Thank you. All right, let's go ahead and jump right in. We are so happy to have you today, Dr. Okhravi. Thank you so much for joining us. I know you are super busy. I just wanted to give you a little bit of background about our presenter today. So our speaker is Hamid Okhravi. He has quite a few things that he has done in his lifetime. I wanted to tell you a few things about him. He is one of the Alfred Abiouness Endowed Professor of Geriatrics. He is the medical director at the Comprehensive Memory Center, and that is with the Macon and Joan Virginia Health Services, Eastern Virginia Medical School at Old Dominion University. A little bit about his background. Dr. Okhravi has received his MD from Mashhad University of Medical Services in Iran, and he completed the internal medicine residency program at the Hurley Medical Center in affiliation with Michigan State University College of Human Medicine. He completed a geriatric fellowship for board certification as a geriatrician at the Mayo Clinic in Rochester, Minnesota. And he was a successful physician in a private practice and was appointed community faculty for EVMS back in 2007. He joined in 2010, Dr. Okhravi joined the Glennon Center as full-time faculty. He now leads a multi-specialty care team and research team that includes over 20 initiatives focused on dementia, Alzheimer's, and caregiver support. The Comprehensive Memory Center participates in Alzheimer's Clinical Trial Consortium, or ACTC for short, enabling the team to tap into national resources and shared expertise to accelerate the development of effective interventions for Alzheimer's disease and related disorders. This is all in the pursuit of the global fight against Alzheimer's disease and dementia. So we will now welcome Dr. Okhravi. His presentation today is Memory Loss, Aging, or a Cause for Concern. Hello, Dr. Okhravi. Thank you for joining us.
Thank you very much for having me. Let me see if I can share my screen here. Okay, can you see that?
We can see it. You might want to put it on just the slide. Yep, perfect.
Okay, great, wonderful. So let me see if I can also activate my pen here. And one more thing that I need to do. Okay, well, as you see, what I'm going to do today is just talk about memory loss, what is normal and what is not normal. Well, probably the most important slide that I have, I put it just at the beginning, because this will determine whether you will benefit from this talk or not. So if you answer to any of these questions, if your answer is yes, then please stay. Otherwise, you can leave and have fun. So do you ask yourself, once in a while, where did you put your keys? For example, you're going to drive somewhere and then you can't find your keys. That happens to me sometime. Or you go to a room and you forget why you went there. So you need to really think about that just for a second, and then it comes to you. Or you're talking to someone and then someone is interrupting you, and then when you're going to restart, you kind of lose your train of thoughts and you don't know exactly where you were. And you ask yourself or people, what was I saying? Or someone introduces themselves to you, and after a minute or so say, gosh, what was his name or what was her name? And you forget. So if the answer to any of these questions is yes, so this lecture then is for you. Otherwise, feel free if you want to leave this lecture. So what I'm going to do, I would like to talk first a little bit about cognition, because if you want to talk about memory issues, we really need to know what cognition is. And cognition is the process of knowing and also being aware and learning and judging. So essentially what you do right now, you're using your cognitive skills to learn about this lecture, understand and learn and memorize, and hopefully be able to share with other people as well. So use your cognitive skills. And those cognitive skills, the main ones, there are 5 of them, 4 or 5 of them. One of them, of course, very important, is the memory, the short-term memory, long-term memory, that's the memory. That's one of the cognitive skills that you use every second. But that's not enough. We need more. We also use our attention. That's another cognitive skill. For example, if you don't really pay any attention right now to this lecture, you're not going to be able to learn about this. And of course, you need to also use your language skills. Language skills is about talking, understanding, writing, and reading. So you need to understand what I say. You need to be able to express yourself if you have a question or concern. And again, you need to be able to read. You need to be able to write. So all of those are language skills. And then the next one is executive function. And executive function is like kind of boss of your brain. It's like kind of those skills that you use to plan something, to execute your plans, multitasking. Those are executive function. Very, very important. And the last but not the least is visual spatial skills, like kind of how you see the world through your brain rather than through your eyes. For example, the size or shape or distance of objects to you. Those are all visual spatial skills. This is one of the skills that you use for driving, for example, very, very often. Well, always. Now, if you take a look at that picture, this is the brain from the side. So we have the front part of the brain here, and then we have the back part. And you can see the main part of brain for these different cognitive skills. For example, the front, that's for attention and executive function. The temporal or temporal lobe is for memory and language. And then the back part of the brain, the occipital lobe, is for visual spatial. So those are the main areas for these different cognitive skills that we use. Now, we're going to talk about the spectrum of cognitive aging. So essentially, it starts from one spectrum is supernormals. That's where we all wish to be. And then, of course, it goes down, typical normal, subjective cognitive decline, and then when people have memory loss, and that's quite severe, like people with mild cognitive impairment and dementia. So we're going to go step by step from each to next and kind of explain what it is. So let's talk first about supernormals. Well, unfortunately, there are not too many of them. It's about 1 to 5% of population, mainly in most studies about maybe 2 to 3% of population. So not really too many people are super normals. And who are they? These are people who are, of course, over the age of 65, like 80, 90, even 100, who have excellent cognitive skills, specifically about the episodic memory, like, for example, remembering dates, names, events, conversations. And these people, when you compare them to their matched age and education, they do much better. In fact, they do superior in those tests that we administer when we do memory tests. So they're called supernormals. But the other name is also super agers. So super agers is like kind of someone who is in their 80s, but when you take a look at their cognitive skills and memory, their performance or function is equal to someone who is much younger, for example, 60 or 65. So essentially, cognitively, they are 15 or 20 years younger. So those are supernormals or super agers. When you take a look at the brain of these people, supernormals, they also, it is different a little bit in terms of volume loss or shrinkage compared to healthy normals. Again, typical normals. Supernormals, they lose brain volume half the rate that people who are typical normal lose brain volume. So essentially, their brain remains bigger when we compare to the same age peers. Now, just to show you some changes or a kind of comparison of brain, as you can take a look here. So we have on the left-hand side a 60-year-old healthy control, like typical aging. And then we have a super ager who is 80 years, like 20 years older. But when you take a look at brain and you take a look at the, creases and the brain tissue, they are very actually similar. So essentially the amount of brain volume loss is similar, for example, in an 80-year-old super ager to a 60-year-old healthy control. Now, what you see here in turquoise here, this is called anterior cingulate cortex, and this is essentially the integrated hub for human socially driven interactions. And as you can see, in a super ager, an 80-year-old, that's bigger compared to a person who is a normal or typical ager and at the age of 60. I'm going to introduce you to one of the super agers that I met a few years ago. And so essentially, this is Professor Reza, who I met a few years ago. He was born on the New Year's Day, 1915, and passed away just probably a few months before COVID-19. So, he, I think he was close to 105 when he passed away. I met him at the age of 99 in a meeting. It was me and my wife, and I introduced ourselves to him. And by the way, he was an electrical engineer. He was an MIT graduate and in a couple of other Ivy League universities. He actually had some theories that he developed himself. Very, very sharp guy. And when I saw him at the age of 99, he finished his 9th book at the age of 99. So I introduced myself, my wife, and we talked about our work. Also, my brother-in-law and my sister. My brother-in-law is a professor, is an engineer, so kind of similar to what he did. So I gave some information in detail. And then I saw him the next year when he was 100. And he could remember anything and everything that I said, including our names, including my brother-in-law's name, which is difficult, very, very accurately. So he was quite sharp at the age of 100. Now, the picture that you see on the right-hand side, he's at the age of 96 playing with a bunch of people who are much younger than him because he couldn't really find people at his age playing tennis. So he was both, I would say, mentally and physically a super ager. Again, we all wish to be a super ager, but unfortunately that's not the case. So the rest of us are typical normals. So normal or I would say age-related memory loss. So we're going to take a look and see what that is. So normal aging, most of us eventually have trouble with, for example, coming up with names and words, tip of the tongue, and multitasking skills that becomes difficult. And our episodic memory, again, remembering, for example, names, different objects and events and conversations become a little bit more difficult. We also get slower in learning new information. For example, if you have a cell phone and you're going to learn new things on your new cell phone, it may be a little bit more difficult, or slower in retrieving old information. It may take a little bit more time for you to remember name of someone that you knew before, or name of an artist or actor. And also we get slower in our processing speed. So we're not as quick as we were before. Now you may ask, okay, well, at what age does this age-related memory loss start? Is it 80? Is it 70? Is it 60? Here's a study by Tim Sothouse. He looked at more than 2,300 people between the ages of 20 and 60. And he looked at 6 different tests, cognitive tests. As you can see here, memory test, reasoning, spatial visualization, and then speed. And he performed 3 tests for each of these different skills, as you can see here. What he found was at very young age, probably high 20s or early 30s, we start to lose memory. And that continues. So essentially, people on this talk, if you are in your high 20s or 30s, you're at top of your game. So that's good for you. Now, here's up to the age of 60, but let's take a look after that. What happens after that? Here's 61 to almost 90. And as you can see, that also drops. And in fact, when it goes beyond 60, the decline is much faster, but still within normal limits. Again, this is age-related cognitive decline. This is normal. All of us who are typical normals will go through that. Now, so essentially this starts at the age of, as I said, 25, 30. It's slow and gradual between 25 and 60. And then after the age of 60, 65, it's more rapid. But still, you can learn new things and enjoy your life. You can create new memories. And something that actually improves is your vocabulary and language skills. So for you becoming a writer, there is never a late moment. So always a good time to probably become a writer. I'm not, but just, kind of a suggestion. Of course, maintaining day-to-day function, you're still able to function independently. Now, these are more vulnerable areas or skills that people, when they get older, they may lose. One of them is, of course, multitasking skills, as we discussed before. The other one is inhibitory control. How many times you've heard from an 85-year-old guy says, well, I'm 85 and I've got to say what is in my mind, right? So essentially that inhibition kind of decreases a little bit, but still within normal limits. And then working memory also declines. And working memory is really the ultra immediate memory or ultra short memory. So for example, if you look up a phone number and you want to dial, but your phone is not with you, and then you're looking for your phone, you need to repeat that number because otherwise you're going to forget it probably within few seconds. So that's working memory or ultra short memory. Episodic memory as well, remembering names, appointments, dates, conversations, recent events. Those are all episodic memory, and people decline in that. And processing speed. In fact, speed is being affected mostly in patients who have typical aging process. But cognitive aging is highly variable, and some cognitive function can improve with aging, believe or not. For example, resilience, for example, your tolerance about, I would say, unsuspected situations or stressful situations, that increases. Your compassion, the way that you feel with people, and that actually gets even better and stronger. Your tolerance to stress gets better. And of course, your wisdom also improves. And that's why we look to older people to get some advice. So those skills get better when we get older. There's something called fluid intelligence versus crystallized intelligence that I would like to discuss as well. So fluid intelligence is really the skills to use logic and really problem solve, or use your abstract thinking to take care of the problems in new situations that you've never been before. For example, if you get a new cell phone, smartphone, and now you're going to figure out how to really work, or if you drive in somewhere that is a new driving environment for you, you really need to use your fluid intelligence to find your way. Versus crystallized intelligence, which is the ability to use your skills, your knowledge and skills that you've had before to solve the problem. For example, whatever you do on a daily basis on your old smartphone or your computer, you're very familiar with. Or, for example, if you drive from home to the grocery store, that you always drive. So that's your crystallized intelligence. And fluid intelligence declines with age, but crystallized intelligence sometimes improve and sometimes maintain. So on the right-hand side, what you can see in blue, that's fluid intelligence. And as you can see, by the age of around probably 2030 here, it actually reaches the peak and then starts to decline. So to give you an example, for example, chess players, it takes about 10 to 15 years to become a chess master, probably around like age of 30, 35. And then after that, they actually decline. So most of these chess masters who are champions, that's the age range that they really have all the trophies that they get. So now, if you take a look at the crystallized intelligence in orange, as you can see, that actually gets better. So one of the examples of crystallized intelligence, if you take a look at Nobel laureates in writing, the writers, those are all older people compared to, for example, mathematicians or physicists who are younger. So that's the difference between crystallized intelligence and fluid intelligence, because for like math or physics, you need more of fluid intelligence versus writing. So the bad news is our brain shrinks as we age, but the good news is that we still retain our wisdom and intellect, and we can continue learning and again, enjoy our life while we get older. Here, just to take a look at two different groups of people. These are three younger people, the average age of 41, and then three older people, average age of 93. These are horizontal sequences of the brain, as you can see here, so cut horizontally. And I want you to compare these two and see the difference. As you can see, I'm going to show you I'm going to mark around the ventricles here for this patient who is, person who is 41. This is the ventricle, and the ventricles are where the cerebrospinal fluid kind of runs. So that's space. And compare that to what you see here. You can see that the space is much, much bigger in the 90-year-old person. And the reason for that is because there's a significant amount of shrinkage around the ventricles. So then we have bigger ventricles. It's just because shrinkage is much, much more pronounced. So when we get older, we have significant amount of shrinkage. So again, like the cognitive skills that decline around age of 30, the brain tissue loss also starts around the age of 30, but that's very, very slow, 0.2% per year. And then it accelerates around the age of 65, 70 by 0.5% per year. At age of 75, in some studies show that there's a 10% loss of brain tissue compared to age of 30. And again, these are all normal people. I'm not talking about patients with Alzheimer's or dementia. I'm talking about normal aging process. So if you take a look at this graph, you can see that by the age of 30 or 35, people start to decline in terms of volume of the brain, and that continues. The question is it different between men and women? And the answer is no. Here, what you see in black, that's men. In red, that's women. As you can see, those two lines are the same. So essentially, the amount of brain shrinkage is the same. Okay, we talked about typical normal. Now we're going to go down the trajectory, subjective cognitive decline. What is subjective cognitive decline? Well, first, before I describe what it is, there was a survey in 2012 of 12,000 participants. And out of those people, by the age of 45, 12.5%, actually 45 and above, 12.5% of people, they complained of noticing having some memory loss during the past year. But only 1 in 4 reported that and discussed it with their primary care physicians. And 1/3 of those people report frequent mental distress because of subjective cognitive decline. And believe it or not, half of those people experienced some functional difficulties because of that subjective cognitive decline. So that's quite significant. Now, the definition is that this is a subjective perception of memory loss compared to your previous level of functioning or thinking. So essentially compared to your baseline. So that's called subjective cognitive decline. And when people with subjective cognitive decline, they come to our memory clinic, memory center, and we evaluate them, the memory test is normal, but it's just they have noticed some changes themselves from their previous baseline. Now, if you take a look at how common it is, so by the age of 65, under the age of 65, 1 in 5 will complain of that. Over 65, up to 50% of people complain of having a problem with subjective cognitive decline. By the age of 85, almost 90% of people will have that. And again, these are people whose majority of their memory is normal. So most people who report subjective cognitive decline in community studies, they did not have real memory problems. So at least that's some relief, specifically in younger patients, because in those younger people, this could be related to, for example, depression or anxiety rather than Alzheimer's or other types of dementia syndromes. Yet, it's important, subjective cognitive decline may be associated with the early brain changes that we see, for example, in Alzheimer's disease, specifically in people who are older. So when people are older, that becomes much more important. Now, there's a condition that we call anosognosia. And that's a condition that we see in 40% of our patients who come to our memory center who have memory loss, either that at the stage of dementia or MCI, and they have no insight to their memory loss. We call it anosognosia. So that's kind of ironic that when people develop more memory loss, they may lose their insight of having memory loss. What are the risk factors for subjective cognitive decline? Well, these are the ones that are quite important. If the onset of subjective cognitive decline is within the last 5 years, and if age of onset is over 60, that becomes more important. And if there's a particular concern, people are quite worried, for example, to the point that they come to our memory center, that becomes more important. And then if people think that their performance is worse compared to their peers, for example, their friends, the same age, if they feel that their performance is worse, then that becomes quite significant. Or if the subjective cognitive decline persists, for example, people who have infection, big infection or hospitalization or surgery, they may have some brain fog, or people who have COVID, right? So you've heard of that. But usually that goes away after a few months or so. But if it stays there, if it is persistent, then that could be something significant. And by default, if someone comes to see us in the memory center for subjective cognitive decline, it means that they are quite concerned. There's a good possibility that this could be something important. Not that I mean that you shouldn't really seek medical advice. I mean that if you're at the point that you seek medical advice, that could be something significant. Or, for example, your spouses or your children, they have noticed as well, and they are concerned. That becomes very, very important. And nowadays, of course, we can do genetic testing by 23andMe and Ancestry.com. You just name it. There are lots of different sites, and those are important as well. There are some genetic predisposition, for example, ApoE, that increases the risk of Alzheimer's disease. This is a study that they looked at almost 45,000 people with a long follow-up, 5.2 years. And by the way, 5.2 years in research study is a long follow-up. They looked at people with subjective cognitive decline. They followed them for 5.2 years. And what they found that if people have subjective cognitive decline, their risk of developing memory loss, either very mild memory loss, we call it MCI, goes up to 1.7-fold, like 70% increased risk, or to dementia, 2 times higher, meaning 100% increase in risk. So that's quite significant. And 20% of patients with subjective cognitive decline will develop real memory loss that we can find in our memory test. So here, if this is, for example, the normal trajectory of typical memory loss or age-related memory loss, people with subjective memory complaint some of them may be in a different trajectory that may lead to Alzheimer's or other types of significant problem. I wanted just to share with you that now when we talk about Alzheimer's disease, we need to be very cognizant. It's not just only the dementia. Alzheimer's disease is a spectrum. It looks like this big iceberg. What we see at the tip or above the water, for example, in our memory center, are people who have real memory loss, and we can find it in our memory test, people who have dementia, meaning that they now become dependent because of the significant memory loss, dependent on their day-to-day function, that's dementia, or they are at the MCI stage. They have very mild memory problems, still able to take care of their business, but it takes probably a little bit longer time. So that's MCI. But underneath that, the water, there's a big part which is called preclinical Alzheimer's disease. And these are people who started having those culprit of Alzheimer's, those plaques and tangles in the brain, probably 20 years before they develop symptoms. And if they have enough time, probably about 70% of them will come to the surface. And if you take a look at population, 1 in 3 people over the age of 65 are at the preclinical stage of Alzheimer's. And this is a very active stage of research. And we have a study related to that as well called AHEAD study. So that's called preclinical Alzheimer's. So Alzheimer's disease spectrum, that's preclinical Alzheimer's, MCI Alzheimer's, dementia Alzheimer's. Here, just to show you that preclinical Alzheimer's disease, meaning people who have those plaques in the brain, it's not benign. This is a study of Harvard study of aging. And you see here 2 groups of people. In blue, those are people who don't have plaques in the brain. And in red, those are people who have plaques in the brain. Those are preclinical people here, preclinical. And when you take a look at these tests, it's actually 5 years study from 0 to 5 years. You can see that those 2 groups of people diverge in all of the tests that they were administered, even by the first or second year. So essentially, this preclinical Alzheimer's is not benign. It means that people are on a different trajectory. Okay, now we're going to talk about the disease stage. So up to this point, we're not really the disease stage, but now we're going to talk about the MCI and dementia stage. So what is the difference between normal aging and dementia? Well, normal aging is like making a bad decision once in a while. We all have done that, right? So how many times I've done something wrong and my, wife has reminded me that that's probably not the right thing you did. Or missing a monthly payment. Now, of course, with all the auto payments, that's not an issue, but this is something that most of us have had done, before. And forgetting which day it is, but remembering later. For example, people who are retired or on vacation, happens actually to me when I go on vacation, I may actually mix it up, whether this is Tuesday or Wednesday. And sometimes forgetting which word to use, that kind of tip of the tongue. and occasionally losing things. You've noticed that you may go, for example, to a grocery store and drive there, park your car, and then when you come back, you don't know where you parked, you don't remember where you parked, and then you use your clicks, right? You're a clicker, right? So that's normal. If it doesn't happen all the time, that's normal. It happens to all of us. But it is not normal if you drive, for example, to a pizza place and then get your pizza and then forget that you have driven there and you come back home without your car. And this is a real story that happened to one of my patients, a 64-year-old gentleman. That's not normal. So that's dementia. So essentially, dementia is poor judgment and decision making to the point that people now become dependent to other people. They can't really live independently, or losing track of the day or the season. Now you need to remind that person 10 times during the day, and they repeat asking, what day is this? What season, or so on and so forth. Or difficulties having a conversation. And now here we're not talking about just tip of the tongue. They can't really communicate, or misplacing or losing items frequently, like during the day, one day, 5 times they lose their cell phone or key. So that's not normal. That's dementia. Now, the difference between mild cognitive impairment and dementia is that mild cognitive impairment, people have some difficulties with thinking or memory, but it's very mild. So we can find it in our memory test. So compared to their peers, they don't really do that good, but still they are independent on day-to-day life. It takes them a little bit of a longer time. The importance of mild cognitive impairment is that 15% of people with mild cognitive impairment, they progress to the stage of dementia in 1 year, and 60% of them will progress to dementia stage in 5 years. So that's quite significant. And that's why we want to really capture people probably at very early stages, probably early mild cognitive impairment, so we have better impact in treating those people. Now, dementia, it's much more pronounced difficulty with memory. Now people become dependent on their day-to-day function. How do we differentiate between age-related memory loss and abnormal cognitive decline? Well, what we do when people come to our memory center, we do obtain a comprehensive history from patients and informants. We separate them to get all the information that we need. We do also a memory test, pen and paper memory test, about 90 minutes test, which is very informative. And then we do brain imaging like MRI, advanced imaging, and that's an advanced MRI. I'm going to show you volumetric studies. And also we do some more of conclusive tests, for example, the PET scan that can tell us whether patients have Alzheimer's or not with a very high accuracy, and we can do spinal tap as well. These are 2 tests that are very, very accurate. Now, first about the neuropsychological testing or memory test. As I said, there are 5 different cognitive skills here. Processing speed, that's probably more of like attention or executive function. So for those 5 different cognitive skills, we do have specific standardized tests, and we administer, and it gives lots of information about patients. It determines whether people have mild cognitive impairment or just only subjective cognitive decline, or it's dementia. Now, what I'm going to do here, I'm going to just present 3 different cases from our memory center about their memory test and then about their MRI. The first one is a patient with subjective cognitive decline. What you see here, this is their memory performance. On the left-hand side, that's the different cognitive skills. For example, here is attention, here is executive function, and then here's the visual, and then here visual spatial. Here's the language, and here's the memory. On the right-hand side, that's their performance. As you can see here, for example, these are percentile. For example, this person scored on this test 58 percentile, meaning that did better than 57 people out of 100. So as you can see, these bars are quite full. Now, I want to just ask you to kind of keep in mind just this patient's performance, which is a subjective cognitive decline, to the second one that I'm going to show. and that's a mild cognitive impairment. This is a patient with mild cognitive impairment. And now that you see that those bars are much, much smaller, shorter. So this is a patient with mild cognitive impairment. Now I want you to just keep in mind this one compared with someone with dementia. And now here's a patient with dementia. You see actually those bars are quite small. Majority of them are 1 percentile or 2 percentile, meaning that 99, 98 people did better at the same age, the same education compared to this patient. Now, what I'm going to do now, show the same patient's memory, MRI. This is a volumetric study. As you can see here, this is for the patient with subjective cognitive decline. We have the left, we have the right, we have lots of different areas, about almost 100 different parts, left, right. Now here in red, it's just one area that is, let's say, shrunken or less than what we expect to see in terms of volume of the brain. Again, these are brain volumes, right? So this patient doesn't really have that, and this is normal, doesn't really have that much of volume loss in the brain. This is a subjective cognitive decline, the same patient. Now I'm going to show you the MCI patient, the same MCI patient that I showed before, the brain volume. This is the MCI patient. As you can see now, you see more of those red areas, red bands. So this patient has more shrinkage in the brain. Now I want you to compare this one with the third patient that I showed before, the memory test that I showed before, the dementia patient. Now you can see that almost most of the areas are in red. So that's how really the evolution of memory loss happens in patients. That's why we really want to see these people as early as possible. This is just to compare all of them together. As you can see, subjective cognitive decline on the left, MCI in the middle, and dementia patient on the right. You can see the progression of those red bars. Now, as you said, we have now more conclusive diagnostic tests. The first one that I'm going to share with you is amyloid PET imaging. These are horizontal sequences of our patients in a couple of our studies. And what you see there in hot metallic color on the right-hand side, that's those plaques deposited in the brain. So you don't really need to be a PET specialist to really differentiate between these two patients. On the left-hand side, that's a negative study. That patient doesn't have Alzheimer's. On the right-hand side, that patient has Alzheimer's disease. This is a 95% accurate test. The cost is about $10,000, but now Medicare covers the cost. The second conclusive test is the spinal tap. As you can see here, we check different proteins in the brain, amyloid and tau, p-tau and t-tau. So now what you see here, there's a big box, as you can see. This is the big box. And then there are 4 small boxes. Now, if patients drop in this box, that is consistent with Alzheimer's. And as you can see, our patient actually is in that box. And again, this is also over 90% accurate. And we do quite a few of them per month, and it's not really as scary as people think it is. So, what are those red flags that probably people need to know if they have subjective cognitive decline to seek medical advice? Age of onset over 60, that becomes quite important. And again, the perception that performance is worse compared to other, for example, friends or the same age people, and that becomes very, very important. Or if subjective cognitive decline stays there, it actually persists for, let's say, more than a few months, and then it progresses, that definitely is quite important. And then if someone who knows you, they are concerned about your memory as well, or your day-to-day function, that becomes more important. Some people who do genetic testing, for example, if they have subjective cognitive decline and they have positive ApoE4, one of those genes that increases the risk, then probably it's good to have medical advice, to just seek medical advice. Family history of dementia or Alzheimer's, that increases risk by 40% if you have one first-degree family member. And if people have multiple cardiovascular risks, that's quite important in and of itself. For example, if someone has blood pressure, cholesterol, diabetes, and smokes, that person's risk of developing Alzheimer's goes up several times. And I think that's also another situation that we definitely suggest to have it checked. Specifically nowadays that we have a couple of medications that they show that they slow down memory loss. This is the first time in the history of Alzheimer's disease now we have a couple of medicine that they can change the trajectory. So it's quite exciting. And we know if you give those medications as early as possible, it's much, much better. And now for those people who have subjective cognitive decline, there are quite a few different studies, and we're going to bring a couple of additional studies for subjective memory complaint people. So feel free, if you are interested in research, to contact us. We have lots of research studies, and here's actually our contact information, our QR code for our website, and also a survey that we have if you are interested in research studies, and then, of course, the contact information for our research staff. Well, I'm going to stop here, and I will be more than happy to answer any questions that you have. I'm going to stop sharing as well.
Excellent. Thank you so much, Dr. Okhravi. I don't see any questions in the chat box, but we did get a few text questions. One of them was personality. If there's personality changes, how does that factor into dementia? Is that if you see somebody with personality changes, is that something then you should go have that person tested?
Thank you. That's a very important question. The answer is yes. Just to give you an idea, based on studies, 97% of people with memory loss and dementia, they will develop neuropsychiatric symptoms. And that could be as simple as like depression, anxiety, apathy, or as complicated as hallucinations, delusional thoughts, agitation. 100% of people, 97%, 100%. So that's quite important. Now, most people probably at the stage of mild cognitive impairment, they start to have depression or anxiety because they understand that something is going on, or even subjective memory complaint. But then when they go through the process, they may lose that insight, and then that's when other symptoms, for example, agitation or hallucinations come. So what is kind of famous in our field, we say, well, at the beginning of issues with memory, patients are depressed, family is happy because family doesn't really recognize any problem. When it goes through, let's say, a few years, then patients are happy and family is depressed. Now, in terms of presentation, there is a percentage of people, even at the stage of mild cognitive impairment, or even at the stage of subjective cognitive decline, that the only thing that we see and we observe is behavioral changes. There is a term called mild behavior impairment. It's like kind of mild cognitive impairment. It's mild behavioral impairment because the main presenting symptoms is really behavioral issues rather than memory issues. So that could well be related to the underlying dementia or Alzheimer's. So if you notice some behavioral changes, some personality changes, that would be a red flag as well. Some of the types of dementia, in fact, the personality change is the main factor. For example, frontotemporal lobe dementia. So this is something that people start changing their personality. For example, they were always healthy in terms of their lifestyle, and now they eat, junk food, and then they start smoking and drinking alcohol heavily, and they have like some sexual disinhibition, things like that. So all of that could be related to underlying dementia or cognitive disorder.
Okay, thank you. We have another question in the chat box. What are the names of the research drugs?
There are 3 medications that got the FDA approval. One of them is called aducanumab. And aducanumab, Biogen just will retrieve aducanumab from the market in November because the other 2, one of them, lecanemab, Biogen has also share on that. So the 2 that will remain would be lecanemab that got the FDA approval on July 6th of last year. And the second one is donanemab that got the FDA approval on July 2nd of this year. These are medications that will slow down memory loss. These are infusion medications that we give to people. In fact, our center was one of the first centers in the nation, entire nation, that we started these medications for people. We have right now, quite a few people on these medications. And but there's a process for these medications. These are medications that not the primary care physicians, not even some of the specialists like neurologists in the area, they do. There should be specific clinics that they deal with patients with dementia, like, for example, ours, that they are familiar with these medications. They have side effects, so we need to make sure that we control for those and do surveillance MRIs.
Okay. We have another question. I have a relative who was given a special blood test and it showed that she does not have Alzheimer's. Can you comment on these tests?
Very good question. Yeah. So this is another exciting area in right now in the Alzheimer's field. There are few tests, mainly that measures one of the biomarkers or culprits of Alzheimer's called tau protein, and the specific name is p-tau 217. That's what it actually measures. And these tests, to be honest with you, it's like kind of sounds like too good to be true, but they are true. So they are very accurate, but they're not yet, I would say, ready for prime time use. We use it in our memory center for very specific patients. Right now, there's an initiative going on about guidelines for using these blood biomarkers, blood tests for detecting Alzheimer's disease, hopefully to replace those two tests that I showed, the PET scan and the spinal tap. In fact, I'm one of those panel members for the development of guidelines. We probably will come up with our recommendation early next year, and we will publish that. So I'm really hoping that it will really change the way that we approach. But right now, for the diagnosis, even if someone has, for example, a blood test that is positive, it needs to be confirmed by those two additional tests that I mentioned, either PET scan or spinal tap. One more thing that I would like to share with you right now here. I do not recommend to have these blood tests done if you're not diagnosed with mild cognitive impairment or dementia, because we don't have any treatment right now. In our research studies, we do use the same biomarker for patients. In fact, we've been using that for the past 3 years or so. So if people don't have diagnosis of mild cognitive impairment or dementia, I recommend not to push or suggest your primary care physicians or specialists to order those tests. Probably at that stage, you probably need to participate in studies if you are interested, because we don't have any medicine right now to give to people at the subjective cognitive decline or asymptomatic stage.
Okay. And then one of the other questions was, what type of physician should we go to if we get a diagnosis?
Yeah. So essentially, people who deal with, like, for example, our center, we are all geriatric medicine, so we are being trained for diagnosing and managing patients with dementia. The other group is, of course, neurologists. And neurologists, I would say behavioral neurologists. Those are subspecialists who are trained to diagnose cognitive disorders, and then geriatric psychiatrists. But of course, overall, the number of people who deal with this situation and treat are not really too many, and there are not too many centers here. But anyway, we are available, and we'll be more than happy to see patients, even if you want to just be checked, making sure everything is okay. Even if you have like some family history, you want to just be checked. We have about 15% of our patients are people who don't have memory loss, and they come just to be checked, make sure everything is okay. And we can certainly provide that assessment. And that's quite priceless, because that becomes your baseline.
Okay, and is there a cost to that? Does insurance cover that?
Yes, the insurance covers covers that. We do probably first the MRI imaging that covers as well. If the memory test shows something, then we will proceed with further testing. For example, that PET scan or spinal tap or other tests, whatever is needed, that will be the next step. If the memory test shows that people have mild cognitive impairment, like mild memory problem or dementia.
Okay. Dr. Okhravi, I know we have a few other questions, but I know time-wise, we have you for 1 hour and we've got to let you go. So what I'll do is any other questions that I see in the chat box or that have been texted to me, I will send them to you. We'll get answers to everybody. Thank you again for joining us. This was really, really informative. I hope a lot of people learned a lot about for themselves and also for family members. Just a quick note that the next Zoom will be in October. We will be discussing veterans benefits for seniors. So thank you again for joining us, everybody. You have a great day. And thank you, Dr. Okhravi, for your time.
Thank you very much for having me. I appreciate that.
Take care. Bye-bye.